Welcome everyone to today's webinar, Attract, Adapt, Implement, and Sustain an Evidence-Informed Exercise Program to Prevent Falls. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman, and I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. Before we begin, we'd like to start today's presentation with a land acknowledgement. Today, we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and unceded territory of the Indigenous people, Canada's First Nation, Inuit, and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and title of Indigenous people of Canada and declare our respect of Indigenous elders, past, present, and future. I would ask that everyone takes a moment to themselves to acknowledge the land where they currently reside. Next, I want to cover a few housekeeping items. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite will be monitoring this space. If you have questions for our presenter about the webinar, please submit them through the Q&A box. They will be answered at the end of the webinar. You will only be able to view questions you have asked and not questions posed by other participants. And everyone always wants to know this webinar is being recorded, and a link to the recording will be sent to all participants in about 1 week or just a few days, along with the link to the presentation slides. I know many of you on the line are already Loop members, but for those who are not, we encourage you to sign up. Loop is the no-cost online communication platform for the fall prevention community of practice, and we use it to bring together members from across Canada to problem solve and discuss how to implement evidence-informed and promising fall prevention practices. Listed on the side here are just a few of the services Loop provides. As a reminder, the recording link and the presentation slides will be posted to Loop in a few days. I would like now to introduce our presenter, Dr. Danielle Bouchard, professor in the Faculty of Kinesiology at the University of New Brunswick, Fredericton. You can find a complete bio for our presenter on Loop, but without further ado, please take it away, Danielle, and you can start sharing your screen.
Okay. And maybe you can confirm that you're seeing the screen here.
Seeing your screen and just waiting for the slide to pop up. And there it is. You are good to go.
Okay, well, thank you very much. Thank you for having me. Today, I'm going to talk about a new initiative that was recently funded by CIHR, and the goal of this presentation today is to see if there's anybody else that would like to take part in this initiative that is lasting 5 to 6 years. So as Michelle said, my name is Danielle Bouchard. I'm located in Fredericton, New Brunswick, and I'm in the Faculty of Kinesiology. I want to start by doing my own traditional land acknowledgement. Like, I respectfully acknowledge that UNB stands on the unsurrendered and unceded traditional Mollustic land. And the reason why we're all gathering together with Loop once in a while is because of all the false consequences. Whether you are on the physical side, social, psychological, and others, we do gather together so we help out ourselves to do better at limiting the consequences of falls, and if possible, limiting the falls altogether. So there's many ways you can actually reduce the risk of falls, and I'm not going to surprise anybody with this, but I want to kind of highlight why are we focusing on exercise or physical activity. And of all the things that exist, why exercise? And the reason is that if you put it all together separately, exercise would be the best single strategies to reduce falls. So if you had to do only one thing, that would be the best bang for your buck. And it's not any type of exercise, and I'll talk more about this a bit later, but it could reduce up to 51% the risk of falling. So normally, or because of that, there's a lot of communities out there that started exercise programming for older adults in the hope to reduce their risk of falls. And the typical scenario looks like this. We have a problem, people do fall, or people say we'd like to have a program put in our community. The second thing is, what is the program? And then the question becomes like, let's get it together, chat with seniors, and then decide what this program could be, instead of sometimes not going to the literature, which is full of well-designed exercise program for fall prevention. So it may be you reach out to get some of the literature, but usually not. And then you will or not evaluate what you've done in your community. And more often than others, you will not have a plan for sustainability. And then how many of you actually like seen programs that everybody loved, you had the resources to do it for a short period of time, and now like the funding is gone and we're back to square one. How do we do this for long term? So we know it works. We know, and when you do it the right way, it can be evaluated and it shows that it works. But we have trouble sustaining this. So the alternate scenario would be to use an evidence-informed strategy or program that exists and yeah, you have it. Use an evidence-informed program, meaning that we know it works already. So might as well taking out of the shelf and then try to do it. Obviously, it will not work all the time because of the context, because of the location, and many barriers and facilitators that are different from one place to the other. But we know it works. It worked at some point. So it needs to be evaluated. And then once we evaluate and it works or not, and there's always glitches, you need to come up with some strategies to approach those barriers and then evaluate again, and then keep going that way. And eventually you'll have something that is close to being not perfect, but like getting closer to like actually reducing the risk of falls, having people enjoying it, having funding that comes in, and all of that makes it like a perfect scenario. But it's not easy to do. And that all like taking something that is from the literature that works somewhere and keep reiterating like the way of doing it. It's called implementation science, where we try to take something that is evidence informed and facilitate the uptake of people that actually need to use this, and then go up to the policymakers. So that is what we're trying to do somewhat in this program. And for those that are not really accustomed to this science itself, like implementation sciences, to my point of view, has two steps. The first one is the intervention. So we want to do like an exercise program for fall prevention. This is what we have. We call it SMART. We call it Zoomers. We call it Stand If You Can. There's many, many options out there. And then we test the effectiveness of this thing, which is the fall prevention exercise program. And we often do it with randomized controlled trial, which is like limiting like the bias out there that would make it look like it works or not. And then once this is the first step, we have something that works. And then I talked about this before. The next step of this would be to implement research looks, what it is exactly is that it looks at how can you best do this now? So what are the strategies to get people to actually do something that we know works? That's one of the the first thing of the second steps. Implementation strategies will be developed so we can try to help people and organization to do this. And then eventually the implementation outcome will be done to know how much and how well people actually do what we try to get them to do. So that's like a bigger like picture of this programming, where instead of like doing a program that should work because based on what we saw lately or what the history is in our community, we just kind of throw it out there and hope for the best. There's ways that you can actually take something that already worked and then you actually like keep working at it to make it even better for your community. So it comes to fall prevention in the community. And we will develop on this, but we needed to know like where we started. So maybe in your mind right now, you can think about how many fall prevention community program exists in Canada. So it is normal that you don't have only 2 or 3 that we're trying to implement, but have in your mind like a number. I'm not going to do a full poll, but you can have in mind like what you think that number is. And the actual number was, when you looked into it a couple of years ago, was 334. And it might be like a little more, a little less now, but just to say that there's a lot out there. And so we probably don't need more programs to be started, but we might actually have to like see which one are actually effective and which one we could replace. And 334 were like identified by doing search on Google of any exercise program that could fit in the community that would reduce the risk of falls. And some of them did answer questions about like what are they involving, and we'll talk more about this. So the question is like, is your program based on current recommendation to maximize the benefits of exercise to reduce the risk of falls? So out of the 334, there's definitely like some that are not following the current recommendation. Things are changing, and then a program that started like 10 years ago might have to be adapted at this point, because the recommendation will change based on the new science. So when you look at the program that we are offering in Canada and the guidelines, what do we see is in Canada, we wanted to like see what is the what does it look like when you compare to like the recommendation. So the recommendations right now are based on a systematic review that was done in 2017 and included 19 or almost 20,000 people. And they seem to, well, they did report that to be effective, or the maximum capacity of an exercise program to reduce falls would be to be offered all year, be offered for 3 hours a week, and focusing on balance. So in Canada, like Touchette et al. Did look into like how many programs actually do this in Canada right now. And it just means that they might do good things, but they might be able to improve a bit what they're doing to actually reach the maximum amount of reduction. And again, like I'll ask you like to think about like, what do you think that percentage is in Canada? So based on the 336 programs that were found, there was about half that did answer a questionnaire, and that's the percentage that we're looking at. And the answer here is 6. So 6% of Canadian community fall prevention programs were meeting these guidelines. So those 3. But when you look into like the percentage of each of those recommendations, it looks like this. So 42% were offered all year, most of them taking off in the summer, offered 3 hours a week, 11%, and then focusing on balance. So when you think about like where there's a gap or somewhere to be improved, it would be to be offered 3 hours a week. And it might be that it could be supplemented by like in-person and online or home-based exercises to actually reach that 3 hours a week. And depending on your setting, it might be hard to do the 3 hours, but there's ways that you can do differently, maybe to reach that. So other gaps that we identified in the literature is some of them are about equity. So most participants are Caucasian women that participate in exercise program in their community. The focus is on people age 65 and older for a reason. There's more falls. However, we can probably like argue now that people that are age lower than 65 now might have more risk factors than they used to have in like 20 years ago. Exercise focus on in-person delivery, and we know now that with COVID-19, it did open up a whole new area of a way of exercising and offering exercise programming. And no program was identified in some places, such as like Newfoundland, Labrador, and as well in Prince Edward Island. And finally, most programs identified were offered only in English. And we know now that about 1/5 of Canadian households don't speak English as their mother tongue. So there's an importance there to like open up and be more diverse. So all of that to come back to what am I going to talk about today. And a couple of years ago, CIHR decided to put emphasis on healthy cities. And the reason is that 80% of Canadians do live in Canadian cities. So if we were able to increase the evidence-informed program, not only for fall prevention, but any, we could have better and healthier Canadians. So the initiative was to support healthy cities intervention and implementation sciences, build capacity in that science, and also mobilize the use of evidence that we look or find within these initiatives. And the challenging part here is in yellow or orange here, it says like without operating funding. So normally you would be like receiving money and we want to do like an exercise program and we want to test the benefits. We buy the equipment, we rent the rooms. But this initiative is coming without any operating funding, meaning that we need collaboration in the community that are programs that already exist, of resources that were already allocated to actually be able to do this. It's not possible to just say, well, let's try something. We've done this a lot, and we know that there's a lot of programs that do exist that works and that will reduce the risk of falls. However, we need to have it picked up at some point. And if you have any academic in this audience, we've usually finished our papers saying like physicians should, or the public health agency should, but they might never get to this. So it is in the upfront now to like have collaboration in the community so what we put together or find that it actually works will be put in place. So that's what led to the AAIMS initiative that we developed with many collaborators and stakeholders. And the idea is to come up with an initiative that would encompassate a lot of different things, that would attract people that are currently not coming to the community exercise programs that are offered in Canada, to adapt the program that already exists to make them more evidence-informed, to implement an evidence-informed exercise program where there's a need, and to sustain all of those once they are evidence-informed in the future. So finding strategies to do all of that. And our main goal is to increase the ability for community groups to offer an inclusive evidence-informed fall prevention exercise program by 2028. So a big vision, but starting with something that already exists makes it a bit easier to digest. So who was initially approached to be part of this initiative? And you'll see a lot of different actors here. Like first, for the attract, the idea is to attract people that are not currently coming to those programs. So Indigenous, men, multicultural groups. These were the first, and I want to point out that it's the original partners. If there's anybody here on the call that would be interested to be part of this initiative, Michelle will send a survey coming up next week with your recording, and you're more than free to like reach out to us that way. So there's the attract, and then after that we have the adapt that is led by Catherine Sibley. Dr. Sibley is at Manitoba, and we did identify some programs that would be interested in different provinces of modifying what they do if needed to make it evidence informed. So reaching the balance criteria, the duration, and also being offered all year long. And the implement is led by myself, and in this group, it's the focus is on implementing a program that's called Zoomers on the Go. We did pick this one for different reasons, but it is evidence informed, and we are going to propose it either in person or online for groups to use if it's needed. And the last one is Sustain, and that's led by Dr. Keller, that is located in Dalhousie University in Halifax. And his role is to take programs or communities that have a program that is evidence informed and find strategies to sustain this program on long term. And all that work will be have an overall guidance with the National Advisory Committee that is mostly composed of people that do have access to Canadian organizations, so we can have some good insights, but also like some help with promotion and recruitment. And obviously there'll be like people aged 50 plus on that national committee, and some people from the 4 different lands here would be represented on that committee. So a bit more detail on each of those four working committees. So the first one, as I said, it was the track. It's managed by Shilpa Dobra at Ontario Tech. And the idea here, or the research question, the main research question that we came up with at first was, what are the best strategies to attract underrepresented groups to evidence-informed fall prevention exercise program? So, and the way we will do this, I'll have a little glimpse here. And again, like if you're interested, like in your own communities to like do this, attract people that are currently not coming to your classes or your groups, feel free to join this working group. The main outcome and how we actually test if that work at the end is we will actually measure the number of underrepresented group that are currently present coming to classes and how that changed once we implemented some strategies. And the way that we are planning to do this is to have interviews with identified groups. It could be men, racialized people, Indigenous people, could be LGBTQ or others that find some interest. And then once we have identified like strategies or reasons, barriers for these groups to come in those programs, then we will test it in some program that already exists in the adapt group and also like in the implement groups, where when we implement a program in a new community, we could test these strategies that were developed and see if it actually helps to increase the number of people that will come to those groups that are considered underrepresented. When it comes to adapt, led by Dr. Sibley, the two main questions that we have is what factors influence the delivery of evidence-informed fall prevention exercise for existing programs? So the idea is to figure out like what are the barriers for current programs to do so, and what are the facilitators, and then come up with some strategies. And then here, the important part is when you do implementation science, like your strategies are really what your intervention is. So we will again like offer some strategies to see if we can help with that, and then we will test. The outcome would be changing the number of fall prevention exercise recommendations adopted by existing program would be our main outcome, where that's our goal is to make it more evidence informed. So did that work? And just to talk a second about this, like when we talk about development of strategies, it's not coming out of like get people together and decide what would be a good strategy. For example, you might have a program going, and then suddenly there's a drop, and you're like, well, maybe if we were to include some exercise equipment, it would help. And then you put the exercise equipment, but you don't really have a reason why you try that. You think it might work. But when we talk about strategies, it's in our case, we're talking about something that is coming from a lit review. So there's other people that tried to do this before. So what did it have to say? Interviews as well. So like, can we interview people that are currently having an evidence-informed exercise program and see what are the organizational factors or limitation are to see if we can learn from this to come up with some strategies. And then the content analysis from lit review or interviews can be done in a more theoretical way. And there's many implementation framework that exists to kind of make some orders, and all of that is being said. And then once we know like the content, we can actually like come up with some strategies that are not coming from people around a table, but coming from a theoretical guideline that shows that it actually worked. When people report these barriers, we can then like link the barriers with strategies that were found to actually work to address this barrier. So it might be a bit complex to get at this point, but the idea is that when we talk about testing strategies, it's not just a strategy that some random person would have thrown and be like testing it. It's really coming from a better or bigger context than this. So the way that Dr. Sibley will do this is right now, like we did identify programs that are existing and are interested to see what they could change. She will sit down with those groups and understand like what are the strengths, what are the barriers, and then explore some factors influencing the program delivery, and then propose strategies to actually increase the elements of the evidence-informed programming. And then we will document, obviously, and then test if that worked. The interest that we had so far in adapting what's existing would be in those provinces. That could change over time. That could be like they shown interest, but they're not interested anymore, or the inverse. Some groups might show up later on. There's definitely like a capacity issue where we can't deal with every group at the same time. So there'll be a staggered implementation for all of these. But that's what we have so far in Canada. When it comes to implement, I'll be responsible for that side of things. And the two main research questions that, well, I guess one main research question we have was what is the effect of an intervention? So we want to like offer implementation planning guide. So when you want to implement an evidence-informed program, do you do better when you have a guide that is like kind of putting together the limitation and the barriers that you might face and see how you can address them, or just as it is, it works as well. The other thing that we want to pursue is understand a bit more like how the online option becomes a part of the programming or not to actually meet the evidence-informed guidelines. It's a new thing in a sense that we've been using like our health rehab online for a while now, but it became like more and more evident that some people actually like the option, and we need to know more about like, is it actually working? Is it different? Is it more or less safe? And the main outcome here is once we have tested the implementation planning guide, do we have more participants or leaders in this case, because it's a peer-led exercise program, more leaders, more participants, and what's the proportion of participants or groups that are using the online option. So to talk a bit about the evidence-informed exercise program that we would implement, it's called Zoomers on the Go. And I said like if needed, in the sense that if there's already a program that exists and people want to modify what they've been doing, it's all good as well. But if there's nothing existing, this could be an option. So right now it is offering across New Brunswick in French and English, and it's done in person, online, or a mixture, meaning that some people could do 2 times a week in person and 1 time online. It's offered all year, obviously, because we want to make sure that we follow evidence. And the main focus is on balance. And there's some exercises as well for lower body strength and flexibility. It is offered to 50 years older and older, although the average is 68. It is a bit lower compared to the literature, and it's something that we'll be able to test the ability to reduce falls in a population younger than 65 plus. It is a peer leader volunteer program, so people that do offer the exercise program are age 50 plus, and they are volunteers in their community. And we did an RCT, the paper is below, and we also look at administrative data, meaning that people that are in the program do offer their Medicare number, so their provincial health care number, and we are able to like eventually follow Zoomers on the Go participants versus those in a province that didn't do the program to see if they're more or less likely to be hospitalized, see their doctor, be institutionalized, all of these. And although we're pretty excited of the fact that we have like 2,500 people that did the program since 2019, if you think about the percentage of adults age 65 plus, if you go 65 plus, we would be like less than 2% of the population that we reach right now. So it comes back and put into context when you think about reducing the risk of falls as a public health strategy, we need to think about big size. And big size means more loss of control, but also like means that there needs to be like some synergy between different level of care or different level of fall prevention or levels of risk. And so coming back to the 2,500, if we were to like think about sustainability, as I alluded earlier in the talk, we need to think bigger than this, because we won't be able to sell to public health that this is a program that actually is appropriate in a large volume, because we would have trouble to like deliver. So it may be that eventually the Zoomers on the Go program could be linked with online recorded videos, like many ways to attend the program, so we can actually deliver to large community and anybody that needs to or wants to join. The interest to implement Zoomers on the Go has been shown like in British Columbia, Nova Scotia, PEI, and also Alberta. Like those 4 provinces have shown interest of like trying to implement Zoomers on the Go and then evaluate how it actually fits in their context. And that's what we're going to aim to do in this initiative. Some of you might wonder, like, what are the individual outcomes? Because there is like a lot of programming, organization outcomes, but on the individual outcome, we on the right side, you see like a Medicare. We want to like take one province that is adapting what they're currently offering. We want to have a province that do implement Zoomers on the Go. And we also want to have like a province which is sustaining an evidence-informed program to compare with the resident that don't do the program. And we could also like compare the outcomes from the 3 different group. But the idea would be really to like do it like individually and see the advantages compared to like people in their province not doing the program. And on the left side, you see that we have in mind to like do testing either in person or online. And when people show interest, they could decide if they want to do the program online exclusively or in person if it's possible. And it could be a mixture of both. In some province, it would be just in person. In some province, they could decide to put the 2 together. And then they would be screened. The screening that we do when we do get people in the Zoomers on the Go is the Get Active questionnaire. So we really want to screen them at high level. And then they get consent. And we would have baseline evaluation. And the idea is that we would follow people up to 6 years after doing 12 months and 6 months to see like the long-term benefits of doing this. Are they like dropping off? Are they, do they keep coming? And there's the individual person, but also like the organization that they come from that we want to kind of follow and see over time, because it's really easy to do anything in 12 weeks. We can start a program, we run it for 12 weeks, and then we see benefits. But it's a different game to try to do it over 6 years and even longer. And on the top of that, it's harder or more complex to do it in different provinces, with some provinces changing first what they're doing to actually make it evidence-informed versus others starting with a program that's already evidence-informed. So really a lot of complexity here, but with a good scheme, we should be able to get many people to be followed over 6 years across the whole country. And the last piece is sustain. As I said, like will be managed by Dr. Keller. And here in this section or this group, the idea is to answer 2 research questions. Like first, what factors influence the sustainability of a community fault prevention exercise programming, and what intervention strategies can overcome the barriers. So once the exercise programs, whether it is Zoomers on the Go on other programs that were adapted to make them evidence informed, we will start trying to like figure out barriers and implement like facilitators to keep a program alive. And the second question was, what is the effectiveness of an intervention to support sustainability of the community fault prevention exercise program? So if we do give somebody a plan, an implementation planning kit to actually sustain their program, is that helpful? And if it's not helpful, then how can we adapt it so actually it becomes helpful? We will use the program sustainability assessment tool to help us guide our work to develop that toolkit. And the idea is to like obviously keep the program going after funding is gone, because that's usually the issue. Some implementation outcome that we'll have with the SUSTAIN group is the number of types of sustainability strategies adopted and the number of organizations continuing to offer the program and meeting also evidence-informed recommendation over time. There will be like different opportunities for academics, and these are listed on the right side. Those are all like academics from these institutions that shown interest of taking pieces of it. And an example of that would be like, what are the factors related to participation and maintaining the behavior? So like once they exercise through the evidence-informed exercise program, they become more active in their daily activity as well. Outcomes online versus outcomes in person. We want to test like the benefits for people aged 50 to 64. And another opportunity that was raised, I guess, for now, but that's just starting. So can we use education session before offering the online opportunity because of the low literacy, technology literacy that people could have? Would it be possible to offer education before having the online option? And if so, is this strategy successful over time? So when you put it all together, the main deliverables are after the 2028, our group would like to have like a guide for people in the community that would like to either attract people in their community programs that is evidence-informed, adapt the program, implement the program, or sustain a program. So the way that we envision this, and we would have like 4 different sections where people could learn or get tools to do this in their community. Because when we think about this, the AAIMS initiative, it could be like replicated in something else that is not exercise and fall prevention. The strategies could be used or could be applicable to other types of exercise, different types of program, not even like necessarily exercise programs. We will guide our main deliverable with something that was developed by Dr. Ian Graham, the stroke recovery and motion planner. If you're looking for tools right now to do these things, attract, adapt, implement, and adapt, there's a good resource there that we will be able to use and adapt to our own context. Some of the example that people might ask, like, how can I get involved in this initiative? And there's many ways that can be done. I put an example here where you could be part of an organization that your goal is to reduce the risk of falls, and you could promote the online delivery, for example, of Zoomers on the Go. It's going to be starting in September, where peer leaders would be anywhere in the country and offer exercise programming. It could be that you identify funding to help these organizations in different provinces to keep offering their program. You can help with the National Advisory Committee, where you help identifying challenges, but also like solutions to do this. You could help with the knowledge dissemination. So when we have findings, we will have like a newsletter that will come up with our stakeholders. You can be part of that and spread it into your networks. For academic on the call, it could be that you supervise students to answer secondary research questions that are more specific of a question that you want to do or want to ask. You could test a new strategy in your community to implement a program, and you could change current practice based on our findings. So this is all like ways that you can be involved in this national initiative. So more specifically, how you can get involved. So there's like 4 different working groups that are going to be put together. We're just at the initial stage right now, and they'll be in the National Advisory Committee. And we are having eventually like a national conference on fall prevention. There's talks that it would be in the Atlantic side, and you can be part of that as well. So when Michelle sends the email with the talk and the slides, you also will find a survey, as I mentioned, that you could actually say, I'd like to be involved with a group that is looking at adapting what's already existing, and the timeline and all of that could be communicate with you with the lead of that working group. So on this, I'm going to stop here because I wanted to make it like short enough so you can have a sense of what the AIMS initiative is and how you can get involved, but have like enough time for people to ask questions about the initiative or how they can fit. So I'll stop here and I'll answer questions.
Fantastic. Thank you, Danielle. That's great. I'll let you leave that slide up actually so people can jot down your email if they wish to. We do have a number of folks who put their questions in the Q&A box. I've seen a number of questions end up in the chat. Just a reminder to everyone, if you want your question answered, put it in the Q&A box. So at the bottom of your screen, there's a number of different kind of Zoom buttons. One of them is the Q&A feature. So please use that to have your questions put there so that I see them and I can have them answered for you. But I'm gonna go right into our questions. So the first question is there a specific process model that has been selected for the implementation?
Not currently. We haven't really focused on that part yet. So like the answer is no. And if whoever asked the question, if they do suggest one or the other, then we're more than welcome for the idea.
Awesome, thank you. The next question: how do you decide to use how did you decide to use volunteers to lead the exercises?
That's a good question. I mean, like most exercise program, it was already started and never been tested. So although I took it over in 2019, this program has been around since 2011. So they started this by having volunteers with a consultation with the community. So older adults got together and said, I don't want to have a young person. That's what that was their words. I don't want to have a young person wearing Lululemon exercise pants and showing us how to do things. I prefer having someone that understands what arthritis is. And that's something that came up at first when they started the program.
That's great. Thank you for sharing. Our next question: is it possible to share what communities in each province are trying to implement Zoomers on the go?
Yeah, for implementation, it's a bit harder because there's an option to be online. So obviously it could be offered to people individually. But in terms of community, we do have a list of community that are interested of getting it in person. And I can have that list. So whoever asked the question, could also email me directly, and I can tell you where are the locations in each province that are interested.
Awesome, thank you. All right, next question. Are there any groups, and you may not know this offhand, are there any groups that are involved in the province of Quebec? Is the intervention offered only via Zoom, or is it also open to the use of other platforms dedicated to tele-rehabilitation specifically?
So the first part, yes, we are involved with the group, the Programme Pied in Quebec, and we are looking into the Move 50 Plus program in Quebec as well. And the idea in Quebec is, I believe, from our first conversation, would be to supplement the Programme Pied, where this is a good program, but there's a lot of waiting list. People want to be in the program, but can only be in the program for 12 weeks during the year. So not making the evidence informed. So if this program could be offered all year long, that would be great, but that's not the case. So there's conversation in Quebec to supplement it or keep the PA for people that are high risk, because the PA is a program that is offered by healthcare providers. And maybe leave the lower and medium risk falls individual to an online platform or in person altogether in Quebec as well. And the second part of the question was
the intervention being offered only via Zoom or other tele-rehabilitation platforms.
Yeah, there's no reason why they cannot be done on any different platform, really. And that could be an adaptation that can be done depending on the context. But right now we're offering on Teams. It's live. So because it's live, somebody could do it on Zoom. It doesn't really matter. And so I don't think there's an issue to offer it in different platforms.
Mm-hmm. Awesome. That's great to know. Our next question, will you know what type of fall a person had? Was it a stair fall or a fall at the same level, for example?
As part of like our individual answers, the way that it works is that once they said yes, then there'll be like multiple questions that would say, okay, where, when, what was the main reason for fall, and obviously we'll have like information about their medication and anything that could influence their risk of fall. So yes, we would have that if the person is willing to answer, in the sense that the way this will be set up is that they answer like a series of questions before. They could also be like personally involved with the testing, either in person with our satellite sites with different universities, or online. So that we did show that it is possible to do like a balance test, a chair stand test. What else that we validated? The 2-minute step test. So there's tests that we usually do with older adults that we can do online. But after like 6 months, a year, and then yearly, it'll be up to the person to answer those questions. And if they do answer the question and they answer, yes, I fell, there'll be a question to understand the context.
Great, thank you. And then the next question is, for those doing it at home, would they be using things in their environment? For example, the bottom step of their stairs, stepping up and down from there.
In the current program, since the focus is on balance, we don't need many pieces of equipment. No, like the answer right now, like people that do it online are not asked to use any types of equipment in their home besides a chair if they need support, or a wall for safety. But to actually do the exercise, the answer is no for the program that we have. But I mean, there might be like some programs that are offered right now in Canada, obviously, that they would require equipment, and that might be something that we look into when it comes to adapting their program.
Right, for sure. All right, I'm gonna go to another question that was a bit related. When they ask, could you, I've lost it now on the list because the list is bumping around, but they wanted you to speak a little bit more specifically about what's involved in the program. Is it a focus on balance, a focus on strength training? Zoomers on the go. I know that that's all you can speak to specifically, but yeah.
I'll bring this slide for this answer. So it is focusing on balance. So like it looks like first 5 minutes is a dynamic stretching, and then they start doing balance, and then a bit of flexibility, and finishing with a cool down. So there's not much of aerobic activity, let's say. And the reason is, and I said like we need to focus on balance, that's one thing, but Dr. Sibley did come up with like a really strong paper a couple of years ago now, 2021, where they look into like 73 different trials, including 30,000 people. And they looked at, if it's really hard task to do, and that's why like I do appreciate a lot what they've done there. But there's many programs that exist that have like so many different combinations. So if you look at the first one, they looked at like functional task specific training, flexibility, strength, walking, unspecified pace versus no exercise. And it list goes on to like different combination. And if you look at the red box here, it seems to be like, if you know how to read this, these numbers, if you look at the right side, you see 0.14. The way to interpret this would be that you're reducing your risk by 86%, the average, if you do these activities compared to when you don't do exercise. And if you look at this column, that's the lowest number that they were able to identify, meaning that that choice would be your best bet. You could do other things, like if you look at the second line, balance exercise plus strength versus no exercise, you would still reduce your risk, but it would be like higher. The 0.57 is higher than 0.14. So when we modify the current program that they had going in the province before, putting into like the science under it, they had like a variety of stuff, like walking for 15 minutes and then strength training and balance and flexibility. And then we really condensed it to these 4 elements: dynamic stability, anticipatory balance, functional stability, reactive balance. And then we kind of, between the balance activities, we do some flexibility to have the mixture, the best. I guess you have to see this as a recipe, and those ingredients seem to be the best mix to reduce the risk of falls. So that's what we implement in Zoomers. So a bit of a 5-minute dynamic stretch to start off with, balance, flexibility, balance, flexibility, a bit of lower strength. And the reason is because of history. They've been doing it forever. They don't want to let go. But really a small amount of it. And then we're done with the program. And that is done 60 minutes, 3 times a week. Some places they do 2 times a week and do 1 online. We also offer pre-recorded classes. So some people prefer just to look at it without being live. So we offer different options, but that's the content of the program.
Great, thank you. All right, our next question, I'm going to collapse 2 questions that are similar. Are the volunteer peer leaders trained? Do they have a healthcare professional background, physical therapist or occupational therapist? Or do they have an exercise background? Wondering about kind of the backgrounds of those peer leaders. Yeah, there's a lot of things in this answer, but the answer is yes, they are trained. And then no, not necessarily having like a healthcare professional background, in the sense that it does seem to attract people that have that as part of their life, even either now or in the past. But they are trained by Fitness New Brunswick, which is the equivalent to any province where that's where you go when you want to have like a certification to teach spinning class, for example. So they do have like a 2-day training where the first one is about the basic of anatomy and physiology, and then what is Zoomers, what are the modification that they can do, but we keep it really limited. So we like to tell our leaders that this program is just a recipe and you're not allowed to change a recipe. So like they do have like continuous education every year, and we do change things if people get tired of it or want to change or try something else. As long as we keep those 5 elements, we can change things, but it's really like they don't have a lot of freedom to change the exercises. Every exercise has like a 1, 2, 3 level. And based on the ability of the person, they would choose 1, 2, 3. But there's not like an option of like, well, let's do what I think would be great. That's not part of it. So yes, they do receive a training. They don't have necessarily like a health professional background. However, what we have here in the province is a collaboration with health professionals, where if you do have, once they're clear to be in the program with like really major events that could lead to risk of major cardiac events, they come in the program. And then if their leader feels that this person is so much at high risk of fall that they become like a danger for themselves because they can't handle that risk, they are asked to tell us, and we do refer them. So it's almost like an inverse of most of the programming out there, where you are referred to be in a program. The way we are trying to set it up in the province is we welcome everybody to come if they are at low risk of cardiovascular disease while doing exercise. But once they are there, if their mobility is limiting them to a point where the leader doesn't feel comfortable to work with this person, then we refer to occupational therapists. That's the way that we have done it here in the province. Great, thank you. All right, a follow-up question actually to the slide that you have displayed. Someone was wondering a plain language definition for dynamic stability and anticipatory control. Wondering about those. What does that look like in practice? Yeah, so dynamic stability would be that you're able to maintain your balance during your movement. So it could be like you're trying to tap in front of you. That would be like maintaining your balance while you're moving. Anticipatory balance would be a postural adjustment before voluntary movement. So you would ask a person like to get up on one leg and then move after. That would be an example. Functional stability would be like your limits ability to shift weight and stay balanced. So you're trying like to go from like a chair stand, for example, would be functional stability. And reactive balance is one that you would have rapid postural reaction following a loss of balance. So you could be, you could have close your eyes and then you touch a partner touch their shoulder, and that's where they have a cue to do something. So you would be reactive to stimulus almost. That would be like an example of that one. Great, thank you. One viewer asks, in terms of sustainability, would you consider integrating other known evidence-based factors along with exercise? For example, considering environmental factors like unsafe stairs, etc.
Yeah, you could have like a multiple, I mean, as long as you follow 3 hours a week and then you're offering all year long and focusing on balance, everything else after would actually like help. Because if you come back to one of the first slides I shown, when you do exercise alone, it gives you 51% reduction of risk, but we still need to get the 49% extra. So that's why we focus on exercise. But once the exercise is in there, there's other things or strategies you can add to the program that would reduce the risk even more. In the Zoomers on the Go, we do have education. We have like one healthcare provider that will have a talk on different topic once every 12 weeks. We also have educational elements that are coming from the injury prevention strategies that would be offered to participant leaders as well. So we do have that piece of education that would include like decluttering and all those things and how you walk during the winter time and those things as an addition to the exercise itself.
Great. The next question, how are you evaluating if the program is successful? They're wondering about metrics like attendance, functional testing, etc.
There's many ways we can actually evaluate, and then one framework that we'll use to evaluate, like I talked a lot about like the implementation side of things, so like when you have an intervention, will it work? But there's all those things that we want to evaluate. So AAIMS is a framework that we can use. For example, reach. How do I reach the target intervention? How do I reach people that are not currently coming? There's outcomes about the effectiveness. There's outcomes about adoption. There's many types of outcome that we will collect. The one that we're more accustomed to would be the effectiveness. Are they actually reducing their falls? But are they increasing their balance or improving their balance? That would be effectiveness. But there's also other elements that are coming from different angles that will be tested.
Great. Alrighty. The next question is, how are people with multiple risk factors and older that are at high risk of fall given exercise? Sorry, how are people with multiple risk factors and older that are high fall risk given exercise? Sorry, there's some words missing in this question, I think. They say, I see that they have to be able to exercise independently. I assume being able to move without concern of falling is inclusionary criteria.
Yeah, it depends on the program. Like when you think about like the Zoomers on the Go, it's done by peer leaders. It's done in community centers. I should say like the leaders have their CPR as part of their training. But nevertheless, what you're saying is that if somebody is really at high risk of falls, it might not be the right program for them. In New Brunswick, we do have a place to go if you have a high risk of falls. That would be like kind of taking care more or so in the healthcare setting with physiotherapists or occupational therapists. But there's a lot more people in the community that are low and moderate risk that could actually reduce their chances of getting at high risk. But depending on the program, like for example, I was talking about the Quebec program, PA. That is the main reason why they have this program is to actually like have people at high risk. So it will depend on the program and who's offering the program and what level of risk they do have. But most of the programs that are out there are actually aimed to like target people that are at high risk, because that's where you would have like more consequences. But if you want to open it up to like more people, the question is that would you reduce your healthcare costs by preventing falls from the beginning and not wait until they're high risk? But from what I hear from the question, like it's not, one program will not fit with all the risk of falls when you look at like all, like if you evaluate their risk.
Right. Awesome. Alrighty, we're 1 minute away from one. We've answered 16 questions. There are still 18 remaining. So Danielle, I leave it up to you whether you'd like to stay on the line for a couple more minutes to answer some more, or we can always provide some written answers to these outstanding questions. Some of them are kind of very specific to Zoomers on the go. There are a couple that are a bit more broad that we could answer in the next couple of minutes and get those off the plate.
Yeah, you can go ahead. And if people want to leave, then we'll have the recording for people to listen to those questions.
Sounds good. All righty. The next question is, apart from the age criteria, do you take into account the people who use walking aids?
And I'm assuming this person is talking about Zoomers on the go again. We are taking people that can come to the program. So as soon as the program, if they can't, what we say is that you can't come by yourself to the program, then you're able to be in the program. And the leaders are trained to deal with people that wouldn't be able to be as mobile to do the program.
Gotcha. Perfect. Thank you. The next question asks, how do you plan to serve the underrepresented population of people living with chronic disease or disability who would typically answer, quote, yes on the Get Active questionnaire? Volunteers are not qualified exercise professionals. What happens to these high-risk fallers with chronic disease?
Again, like it would be easier to answer that question if we would only have like one program in one province and one city, but it will depend on like how the setup is done in each of those provinces. In New Brunswick, they wouldn't be allowed to be in the program, like the Zoomers on the Go program, but they would be referred to an occupational therapist to be assessed and have something for them that would be more suited for their need. But it's not because you have a chronic condition that you would automatically have a yes on the Get Active questionnaire. And there's also another thing that I should say, the Get Active questionnaire now has been modified about 2-3 years ago, where people could say, I am assuming the risk. I know I have some risk of like, because of my diabetes not being controlled, but I prefer doing the program or any type of exercise program than being like not. And that is something that they will accept as their own risk, and they will be in the program. So there, of all the program that we offered in the last 4 years, I think the numbers is like about 3% of people would have answered a yes on the Get Active questionnaire and had to be seen by. Some people will actually see their doctor and come back with clearance and be in the program. That's also an option.
Awesome, thank you. All right, the next question, again, I'm gonna kind of collapse 2 questions. They ask, can you elaborate on, quote, focus on balance, what that means within the program? Is there a specific volume that is targeted within the 3 days per week? And someone else also asked about balance, wondering if it was static versus dynamic balance. And yeah, if you have any other details to share about that, Danielle.
When we say focus on balance, I think to make the criteria yes or no, you would have to be at least 50% of your time, like more than 50% of your time would be like the focus of this program is mainly on balance. Yeah. But when it comes to like what type of balance, comes back to the same thing where we would want these dynamic, reactive, functional, and disciplinary balance activities and not static balance as part of it.
Yeah, absolutely. All right, the next question. Do you have tools to assess compliance of persons to follow and practice strategies?
I'm not sure I understand. Like, so if people are complying to the program?
I'm going to assume that's what they mean.
Yeah, like meaning that if they come or not, like we do follow if they come or not, but the compliance itself is something that is missing, I would say, in the literature, where what are they doing when they're doing it? And then there's a tool that exists to assess the intensity of the imbalance. And that's something actually that we want to test, where how much imbalance did you feel? Because you could have like, if you don't push yourself to be in the being unstable, like, are you actually improving more or less your risk of falls? So like, it is something that we want to look into, but it is hard to quantify. You can say that somebody came 60 minutes, but what they actually did during that 60 minutes could be diverse from one person to the other. It is a hard one to do. It is easier on the program level to identify people if their program is offering what we expect them to offer. That's easier to measure. So like we could ask questions to the participants, like, did you, most of your time that you were in the program, would you say that you did balance, for example? Was it offered 3 hours a week? Was it offered all year long? That's easier, but at the participant level, it is harder to quantify.
Great, thank you. All right, next question is, exercise is medicine, and exercise professionals across Canada and around the world, registered kinesiologists, etc., spend 4 years in university exercise sciences, but we constantly look for ways to deliver exercise therapy free or with volunteers. We need our researchers to use our licensed exercise professionals to deliver exercise as medicine. This would help get professional exercise therapy services covered like other allied health professional services. Why do we continue to use volunteers, they ask?
Yeah, there's many reasons for that, but like I agree. I mean, I train kinesiologists. That's what I do like for a living, right? I was also like in university degree. Like, it comes back to the public health issue. That's the problem. There's two problems, my point of view. The first one is what are we, and that's what we're trying to like. It's hard to do in all provinces. Ontario was able to get their College of Kinesiologists, but what are we trying to get people to avoid, right? What are we, when we have like a profession that has their college, is because we want to protect the public. You want to protect them from what? And what are the risks of somebody doing exercise versus not doing exercise? And it's been when you ask the question to public health, it seems to be more advantage to do exercise, no matter what that is, compared to the risk of doing any type of exercise. So that's one. The second one is the cost. And I mean, I do get the point that if we never push for it and then never put money for it, thinking that it can be done for free, and I agree. When we want to do an exercise program for 2,000 people, it is feasible. But when it comes to kinesiologists, in my point of view, like it is mostly done, like the kinesiologists are really there to like promote exercise for people that don't exercise, not necessarily with chronic condition or not, but just everybody should move the same way that everybody should sleep. So it is harder to pay a health professional to intervene with when you look into like how many people don't do the behavior. So there's a cost, but I mean, I do agree that if we do say that it's feasible to be done without kinesiologists or registered kin, then it will never happen. So it's kind of the catch-22, but we are again like happy about our Zoomers on the Go program with reaching 2,500 people, but we need to really do a good job. We would need to reach like, I don't know, 100,000, like a lot more people. How can you like sell the idea that you need that much money for that specific problem, because there's other problems as well. So it is a competing priorities, I would say, but it is complex, and we could talk about it for a full hour.
It's a whole other webinar.
Yeah, it's complex.
Yeah. I've got some kind of rapid fire questions about Zoomers on the go. So I can run through those quickly. One participant asked if we would like to implement the program in our community, where could we get the training to teach Zoomers on the go? I'm assuming those questions would be answered if they filled out the survey that gets sent around, Danielle?
Yeah, like if they want to be interested in the implementation, yes. We would have to look into like if they are in a province that already have something, but you just are not aware of before. And then also obviously people can register directly online. We also have like the hybrid model that was developed lately where people get together anyway, but they don't have a leader. So they have a leader that is online, but everybody's in person. And to get the training, like we are right now, like in the process of like, how does it work when somebody wants to have Zoomers right now we're looking in Alberta, because Phineas New Brunswick offers. I have meetings about this tomorrow, I believe. So we're there like thinking about like, how do we transport the training? Is it people in these provinces doing it, or are we like, anyways, it will be feasible, just that we are developing the ways of doing this now.
Right. Another person asked, is there a cost to complete the leader training?
There's a cost, but it's always been free. I mean, I don't see how you can get somebody to be volunteering and pay for getting trained to be a volunteer. So it is, there's a cost associated with it. And then we are having like long-term funding now to cover that piece through the government of New Brunswick. But there's a cost, but not for the leader itself.
Gotcha. Great. Thank you. Is the program limited to 12 weeks and then discharge, or would participants be able to continue their participation past the 12-week framework?
It needs to, like, I don't know, like how it came across, but it is, I guess it is 12-week sessions, and it's just like about registration. So people are more than welcome to keep doing the program over and over and over. And that's the idea, is that if it's offered all year long, but you don't do it all year long, like you're not reducing your risk of falls. It's not a 12-week thing a year that will say, well, it could reduce your risk, but it's not optimal. So yes, it is made on purpose, where every year, every term we have, obviously, like the summer term is less people, but I say that, but now that the online option is possible, I have like multiple pictures of people sending this from the cottage. There's terms that it is less people, but there's about 80% of our group is coming in over and over, and 20% new showing up every term.
The next question, just confirming that the target audience is community dwelling older adults rather than those individuals in supported living.
Yes.
Yeah. And just seeing, there's a couple of questions that have already been answered through another question. Right. Okay, this is the last question that kind of offers some different information. How early would someone post-fall who had surgical interventions be able to participate in the program?
It's a good question. Based on the Get Active questionnaire, it would take them, they might be, like, they could be a part of the program if they have clearance earlier, but normally, if I think about all the question, I think they would be like asked to wait for 6 months, depending on the surgery. But yeah, if they clear the Get Active questionnaire and they feel like coming, they could be in the program.
Yep, for sure. Alrighty. So this is for sure the last question now. I'm gonna cut us off, but they ask, I know that there are some people that just do not like exercise or would like to see options that are framed as social, fun, creative, artistic, etc., dance, flexibility, tai chi, self-defense, functional mobility, and others. Are there programs like this in the evidence-based programs beyond Zoomers on the Go?
Yeah, it's a good question, because I mean, it is about the identity too, right? When you say like you want to be involved in an exercise program, our advisory committee did tell us like that's based off like older adults or like people, different stakeholders in the province, and they say like stop using the word exercise when you approach people to be in the program, like participate themselves. Because if you say exercise, the people will feel that it's going to be intense, and they might not adhere to that. And on the flip side, people might think that it will be intense, and they're disappointed because it is more gentle exercise where you focus on your balance. So that is one thing. And the second thing is, we're never going to be finding something that works for everybody. And I mean, you could, it's almost like giving vegetables to your kids, right? You could sneak it in and call it something else so they show up and they actually like it. But you could also like be clear that this is what it is. And if it doesn't fit for you, maybe there's other option. I mean, Tai Chi is a good option, and there's been like evidence showing this, but it is rare that you find evidence on multiple things, because it's super hard to like control, is it this one or this part that really helped? So like it is hard to find evidence that would have a combination of like 12 different things that people do within their program, because it's hard to figure out like which one is the useful ones. But doing exercise is also good for other things and reducing the risk of falls. So if you adhere to something else, there are benefits, maybe not as much for the fall prevention, but there is benefits. There are benefits.
Fantastic. All right. Well, Like I said, we'll keep it at that many questions. Clearly, people are engaged, they're interested. Thank you again, Danielle, for a fantastic presentation. You're clearly an expert in your field. It was so great to see all the hard work and how many helping hands were involved in this project and will be involved in this project over the next 6 years. It would be great to provide an update as the project goes along. We'll love to see how things are going, and we really appreciate your time today, and thank you for staying a few minutes longer to answer all these questions. But like I said, everyone, you'll be getting an email in a couple of days with the recording, a link to the slides, and we'll get some more information for those who want to get more involved. That will be a part of the email as well. So thank you again, everyone, and I hope you have a great rest of the afternoon. And thank you again to Danielle.
Thank you.